Demyelinating disorders. Multiple sclerosis, or MS, is a chronic demyelinating disorder of the central nervous system of unclear etiology, though it is believed to be immune-mediated. The disease primarily affects young adults, with a female-to-male ratio of approximately 2:1, and is most commonly diagnosed between the ages of 20 and 40. The risk of developing MS increases with distance from the equator during childhood, and it is more frequent in individuals with a personal or family history of autoimmune disease. A genetic association has been identified with the HLA-DRB1 locus. Multiple sclerosis can present in several clinical subtypes, including relapsing remitting, which is the most common, primary progressive, secondary progressive, and progressive relapsing forms. The hallmark of multiple sclerosis is the occurrence of multiple neurological complaints that are separated in both time and space, meaning the symptoms arise at different times and affect different areas of the central nervous system, not explained by a single lesion. As the disease advances, permanent neurological deficits tend to accumulate. A classic finding in MS is bilateral internuclear ophthalmoplegia, which results from demyelination of the medial longitudinal fasciculus on both sides and leads to impaired horizontal eye movements. Patients may also present with limb weakness, gait instability, paresthesias, Lermite sign, which is described as an electric shock-like sensation radiating down the spine or limbs with neck flexion, blurry vision, vertigo, nystagmus, urinary retention, bowel and sexual dysfunction, depression, and cognitive decline. Symptoms can transiently worsen with heat exposure, such as during a hot shower, a phenomenon known as Udhoff's phenomenon. The disease course is typically unpredictable, with relapses occurring on average every 1.5 years, each lasting between 2 and 8 weeks. Neurologic symptoms may remit completely between episodes or gradually become progressive over time. Among all forms, relapsing remitting MS generally carries the best prognosis. Pregnancy may be associated with a reduction in MS disease activity. However, there's an increased risk of disease exacerbation in the postpartum period. Diagnosis of multiple sclerosis relies on a thorough clinical history and neurological examination, supplemented by imaging and laboratory findings. The most accurate diagnostic tests include magnetic resonance imaging, MRI, and lumbar puncture, LP. MRI is the diagnostic test of choice and typically shows multiple asymmetric, often periventricular, white matter lesions, known as Dawson's fingers, which are especially prominent in the corpus callosum. Active demyelinating lesions enhance with gadolinium contrast, helping to distinguish new lesions from old ones. Cerebrospinal fluid analysis reveals an elevated immunoglobulin G, IgG, index and the presence of at least 2 oligoclonal bands not found in the serum. Findings that, while nonspecific, strongly support the diagnosis in the appropriate clinical context. A lumbar puncture is usually reserved for atypical cases in which the diagnosis remains uncertain after MRI evaluation. Treatment of multiple sclerosis is aimed at controlling acute exacerbations, modifying the disease course, and managing symptoms. Acute relapses are treated with high-dose intravenous corticosteroids, while plasma exchange may be used in patients who do not respond adequately to steroids. Disease-modifying therapies are used to reduce the frequency and severity of relapses and to delay disease progression. Natalizumab and ocrelizumab are highly effective options for patients who have not responded to other treatments. Although natalizumab carries a risk of progressive multifocal leukoencephalopathy, PML, patients with less aggressive disease may be treated with oral medications such as dimethyl fumarate or fingolimod. Beta-interferon and glatiramer acetate have the highest safety profiles but somewhat lower efficacy. Symptomatic therapy is an important part of MS management. Baclofen is used to reduce spasticity. Cholinergic medications help relieve urinary retention. Anticholinergics manage urinary incontinence. Carbamazepine or amitriptyline can be prescribed for painful paresthesias, and antidepressants are used to manage associated clinical depression. Guillain-Barré syndrome or GBS, is an acute, rapidly progressive, autoimmune demyelinating disorder that affects the peripheral and cranial nerves, leading to muscle weakness and potential paralysis. It is commonly preceded by a recent infection, most notably Campylobacter jejuni, but can also follow viral infections or, in rare cases, influenza vaccination. The immune response triggered by the preceding infection leads to the production of antibodies that mistakenly attack the myelin sheath or axons of peripheral nerves. The most common subtype is acute inflammatory demyelinating polyneuropathy, while another variant, Miller-Fisher syndrome, is characterized by ophthalmoplegia, ataxia, and areflexia. Approximately 85% of patients achieve full or near-complete recovery, though the process may take several months to a year. A useful way to remember key features of Guillain-Barré syndrome is through the mnemonic, the 4 as of GBS. Acute inflammatory demyelinating polyradiculopathy, ascending paralysis, autonomic neuropathy, and albuminocytologic dissociation, which refers to increased albumin in the cerebrospinal fluid without a corresponding increase in white blood cells. Clinically, GBS typically presents with progressive, symmetric, ascending muscle weakness that evolves over hours to days, beginning distally in the legs and moving proximally. Deep tendon reflexes are decreased or absent, areflexia. As the paralysis progresses, it may involve the trunk, diaphragm, and cranial nerves, leading to facial weakness, dysphagia, and potentially respiratory compromise. About 25% of patients develop respiratory failure, requiring intubation and mechanical ventilation. Autonomic and sensory nerves may also be affected, resulting in glove and stocking distribution paresthesias and autonomic dysfunction, such as orthostatic hypotension, cardiac arrhythmias, and bladder or bowel disturbances. Hyponatremia is a potential complication and a poorer prognostic indicator. Diagnosis of Guillain-Barré syndrome is confirmed through a combination of clinical presentation and diagnostic testing. Nerve conduction studies demonstrate diffuse demyelination, evidenced by decreased nerve conduction velocity. Lumbar puncture findings show an elevated cerebrospinal fluid, CSF, protein concentration greater than 55 mg DL with a normal white blood cell count. This characteristic finding is known as albuminocytologic dissociation. It is important to differentiate GBS from tick-borne paralysis, which also causes ascending weakness, but is distinguished by normal CSF findings and the absence of autonomic dysfunction. Management of GBS focuses on supportive care and immunotherapy. Frequent monitoring of vital capacity and negative inspiratory force, INGEF, is essential to assess respiratory function and determine the need for intensive care unit admission for impending respiratory failure. First-line treatments include plasmapheresis and intravenous immunoglobulin, IVIG, both of which are effective in reducing the severity and duration of the disease. Corticosteroids are not indicated in the management of GBS, as they have not been shown to improve outcomes. Once the acute phase resolves, aggressive physical rehabilitation is crucial for recovery of muscle strength and function.